The effectiveness of intraoperative radiotherapy was studied in the Target A trial, which asked the question, can targeted intraoperative radiotherapy achieve local control comparable to traditional radiation, which is usually administered over several weeks? The study was a randomized controlled trial comparing targeted intraoperative radiotherapy in women undergoing lumpectomy with stage 1 or early stage 2 invasive ductal carcinoma. Half of the participants were assigned randomly to receive intraoperative radiotherapy using the target method, which delivers intraoperative radiotherapy in a single fraction or single dose to the lumpectomy site at the time of surgery. The other half were randomly assigned to receive traditional 6-week course of daily radiotherapy delivered to the entire breast after recovering from surgery. Now, nearly all of the evidence supporting the benefits of radiation therapy following breast conservation are based upon women receiving radiation to the entire breast in 4 to 6 weeks of daily treatments administered after surgery in the radiation oncology department. This has been an effective treatment, but it's one that has been associated with significant inconvenience and treatment noncompliance, especially for women living greater distances from the radiation oncology center, some of which may simply choose to undergo mastectomy to eliminate the need for daily radiation treatments. Now, when targeted intraoperative radiotherapy is initiated, low voltage X-rays are delivered directly to the walls of the lumpectomy cavity, followed by quick attenuation or the falling off of the strength of the dose as the X-rays travel farther from the source. This loss of strength effectively spares more distant tissues the effect of radiation. I'm happy to present this image of the publication reporting the long-term outcomes of the Target A trial, published in June 2020. And as you can see, I was one of the co-authors of the publication. This slide shows my co-investigators from 33 centers in 11 countries with whom I've collaborated over the last 15 years, a truly international effort. So let's get to the study results. The next 2 slides summarize the patient and tumor characteristics of study participants, showing that most of the patients were over the age of 60, although 40% of the patients were under the age of 60. 80% of the tumors were smaller than 2 centimeters. 80% of the tumors were low to intermediate grade, but 20% were high grade. 80% of the patients were node negative. 90% were ER positive. 80% were PR positive. 15% were HER2/neu positive. 70% of the patients had screen-detected breast cancer, meaning that their cancer was diagnosed by mammography. 80% of the patients were compliant with anti-estrogen therapy, and about 20% of the patients required chemotherapy. Basically, these characteristics mirror the typical breast cancer diagnosed today with screening mammography. Now, the main goal of the trial was to compare the length of survival without a recurrence within the breast, what we call the local recurrence-free survival, comparing targets shown here as a red curve against external beam radiotherapy or traditional radiotherapy shown here as a blue curve. And what you see is that the curves are virtually overlapping with no statistical difference seen between the 2 treatment options. This slide compares the 2 treatments in terms of the patient's survival without recurrence outside of the breast, such as in the liver, bone, or lung. We call this distant disease-free survival. Here too you see no statistical difference between those who received targeted intraoperative radiotherapy, the red line, versus those that received external beam radiotherapy or postoperative radiotherapy, the blue line. Again, no difference between these 2 groups in terms of their distant disease-free survival. This slide specifically looks at those who live without a recurrence of breast cancer anywhere within the body, what we call the breast cancer specific survival. Here again, you see no statistical difference between the 2 graphs, the red graph and the blue graph. Now we'll look at the overall survival, which refers to the survival without dying of any cause. Again, you see no statistical difference between the 2 treatment options. In fact, the only situation where we observed a significant difference between the 2 treatment options was in the non-breast cancer mortality, or the rate of death from causes other than breast cancer. Here we found a higher rate of heart attacks and lung cancers, shown here as this higher blue curve, in women receiving traditional radiotherapy compared to target, thus proving that target is safer in terms of avoiding injury to the heart and lung. Here's a summary of the Target A trial results comparing 10-year outcomes between the 2 treatments, showing equal results for all endpoints except for deaths from other causes, which were higher for traditional whole breast radiotherapy. Separately, we have published results showing that IRT is safer in terms of side effects on the breast, that is associated with lower healthcare costs, and that recipients of IRT show improved quality of life compared to traditional whole breast radiotherapy.